Hello, everyone. This is Jongho Lee from Seoul National University.
There are three topics that I will cover today. They are all targeted for the Parkinson's disease. As the disclaimer, I don't, at least in this talk, I don't talk much about biophysics, and it is all about tools. And there are three tools that I will present. The first one is this susceptibility map weighted imaging. That's our approach of detecting this nigral hyperintensity sign in substantial nigra. Another one is sandwich neuromelanin imaging. Again, this is the new vendor-neutral, high-quality neuromelanin imaging, despite the source of the contrast that we are not sure of. Third one is chi separation. This is advanced QSM methods that targeted to quantify an iron and myelin separately. Well, let's begin with SMWI. As you already heard, and I believe that almost everyone in this audience already know about this one, the nigral hyperintensity sign in substantial nigra. I believe this one was the first study done by Kwon. They scanned a bunch of healthy controls and Parkinson's patient at 7 Tesla in such a high resolution, and was identified this small structure within SN as a biomarker for the Parkinson's disease. And that's about 10 years ago. And after that, there has been a number of studies coming up and naming as swallowtail, as you probably heard about it a lot. And sometimes it is also called as nigrosome 1 structure. And at least for me, it really didn't matter for a long time. So we tend to use nigrosome 1 as it is a simple term to use and communicate. But after reading papers from Nick's lab and also from Max Planck Institute, I finally settled myself to use the term of nigral hyperintensity so that I can stay neutral on the point. Well, after the first study, we begin to work on some of the other points of this nigral hyperintensity points and demonstrate that we can find the clinical laterality agreeing with our radiological imaging signatures, which is a very good sign that it carries some of the important clinical information. And also we were able to differentiate the idiopathic PD from drug-induced Parkinsonism. And that's another good sign that the signature has some clinical meaning. Well, the challenge back then is not everyone has 7T, and even Seoul National doesn't have 7T. So I get a lot of requests what we can do about using 3T to detect this hyperintensity in a reliable and stable way. And if you think about the structure, substantial nigra itself is a very small structure within the brain. And the one that we have to identify is even smaller structure within substantial nigra. And we need certain CNR and SNR. And the other restriction is 5 minutes, as we heard from the previous discussion, 5 minutes is already too long for the Parkinson's patients. So I believe the cutoff time is like 5 minutes and less. And to combine, to have all these targets, we've been searching for a way of doing a better imaging using our multi-echo gradient echo type of sequence. And the one that we came up with is this susceptibility map weighted imaging. I believe Mark has different name for this one, and I believe the papers are published at the same time when it comes to the methodology. And his name is True SWI, and you can almost equate the two as the protocol, or at least the reconstruction tool. And if the reason why we are motivated of using this one is based on these 4 images. If you look at the magnitude, yes, you can see some of the signatures of this hyperintensity. And when it comes to the phase, you really need to do the deconvolution of the dipole pattern, which results in this QSM map. And also that also shows the signature of the nigral hyperintensity. On the other hand, SWI, the conventional approach Mark has developed, has some artifacts in SN regions, so that itself may not be a good choice. So we begin to combine these two contrasts so that you can have best contrast as compared to the other sources. And we demonstrated that we can increase the CNR by 40% by having this SMWI imaging. By the way, this SMWI imaging for nigral high intensity does not really mean the methodology itself. It also means how you set your resolution and your TR and input times, and then even the orientation for covering the volume. And these are the combinations that we came up along by mostly suggested by Professor Eung-Yup Kim at Samsung Hospital now. Previously he was at Gill Hospital and he now moved to the Samsung Hospital. And it's really his work that he compared a lot of different conditions and come up with a protocol that really give you a nice high contrast, high detectability for this nigral hyperintensity. And one thing that may be very different from other studies is the orientation. So instead of having this axial or ACPC line, we begin to collect the data in oblique axial or oblique coronal, depending on how you see the orientation. And the scan is parallel to the bilateral hippocampi. And once you acquire the data in this orientation, it doesn't look like the swallowtail anymore, but still it gives us, at least for us, give us a better detectability. And these are some of the examples. This first column is the healthy volunteer. The second column is the early stage PD. Third volunteer is the advanced PD case, where these are different slices in the oblique axial, and this is the reformatted result of the oblique coronal images. And once you have these images available to you, then we can have some abnormality grading as shown on the right, so that you can have detailed grading of the patient. And if I can suggest, point out some of the studies done using SMWI, and these are just half or 1/3 of the papers that we that are published using this technique. And the most prominent one is this prospective multi-center study of 10 centers, recruiting 257 subjects, some with neurodegenerative Parkinsonism, the other with non-neurodegenerative Parkinsonism, and some controls, showing you a very high accuracy when you have this technique with trained radiologists. Another study demonstrates that this SMWI performs better than SWI. So it seems that this reconstruction technique is necessary to get the high performance in diagnosis. And also, it works for the early stage PD as well, as demonstrated in this study from Chinese group. And different part of the substantial nigra seems to be involved in different stages of the Parkinson's disease, as demonstrated in these two studies. Well, as we go along the studies, one thing that we got really disappointed was this last study, that we thought that initially, or at least we hope, that we can have this technique specifically for the Parkinson's disease, and that didn't happen. As you probably know, a lot of different diseases like PSP or some subtype of MSA also showed loss of nigral hyperintensity. So there are limited specificity to the Parkinson's disease, but still it really give you some of the information that are valuable for the clinical diagnosis. And based on all these clinical outcomes, Dr. Kim has suggested a new way of following the procedures for the clinical procedures for the patients, so that we can reduce the amount of DAT PET scan for the patients. So if I can summarize the first tool that I present today, it is about this nigral hyperintensity by using SMWI. It gives you high CNR that are necessary for the detection of the patient. And also it's about 4 minutes and slightly longer than that. And now we are doing this deep learning reconstruction so that we can reduce the scan time to less than 3 minutes. And it seems that the method seems to work and will be presented in this upcoming ISMRM. Well, another thing that we noticed is the result is very sensitive to the resolution, or detectability is very sensitive to the resolution and CNR. as well as experience. So, and this experience part is difficult thing, as you need to train your colleagues, and there are it depends on how well how welcome you are to the new technique. Sometimes they are willing to learn more about how to read the images, or they are not willing to do it. And it was really hard to do it with a few examples. So we ended up with creating this website, and so that we can have some sample data sets on the website. And now the website is functional, and we have about 20 something examples that you can go and evaluate by yourself. We'll be keep updating this website so that we can have better acceptability of the technique. Anyway, the tool and protocols are available per request. So if you want to try it, and it's free and I'm willing to share with you. Well, one of my colleagues who did a project on this topic was Dong-Hoon Shin, and he saw a business opportunity out of this one and developed the neural-led version of the classification and the Niagara hyperintensity volume measurement. And what he demonstrated with his tool is, his tool seems to perform as well as the experts in the field. So I believe there is a way of making this one as a product and make it available for people who want to use it without training. So now let me move on to the next topic, which is sandwich neuromelanin imaging. As we already heard, this neuromelanin imaging seems to be a very powerful tool. And at least from my perspective, I believe this is the contrast combination of the MT weighting and T1 weighting. Based on my experience, if I don't have MT weighting, the contrast decreases. So I believe the MT still suppresses the surrounding white matter tissues so that we can have better contrast of this area. Having said that, I don't mean that the effect of MT is really helpful in increasing the neuromelanin signal itself. It may be just visualization effects that may complicate our understanding of the signal itself. But having said that, at least this neuromelanin MRI may not be perfectly from the neuromelanin concentration, but give you some insights on how patients look like based on their volume and the contrast rate. And that may be very useful to apply it and analyze the data sets. Well, if you are familiar with MT, you will say that this is one of the curse, I would say that curse in the field in a sense that the MT pulse, the product pulses are different from vendor to vendor, and maybe different sequences have different versions of the MT pulses. Their off-resonance frequency, their flip angle, their shape are all different. That means you have non-consistent contrast when you apply your acquisition from one vendor to another. And for our point of view, we want to get one sequence that works for all vendors. So it is vendor neutral sequence. And we also don't want to do any sequence programming. So we want to have these product sequences that can be vendor neutral to a certain extent and still getting high quality melanin MRI. And our suggestion is having this regional saturation RF pulses, both superior and inferior to the imaging volume, so that we can have these incidental MT effects from these off-resonance excitation pulses, if you say that way. And that's what we call as sandwich neuromelanin imaging, as our saturation bands are sandwich of this imaging slab that we are targeting for. For the T1 weighting, we have this short TR and appropriate flip angle, and we identify two different TRs that we can use it for, two different flip angles with two different number of saturation pulses that you can use it to get a consistent and neuromelanin contrast out of the two combinations. The use of two saturation pulse is much easier to prescribe on your scanner, so that's the target we are using it. On the other hand, this 4 saturation pulse option give you the SMWI at the same time as this neuromelanin imaging. So it has this advantage at the end. We tested for 2 different resolutions shown here. It takes about 5 minutes and a half. And that's a little bit of challenge, as you heard that, Parkinson's disease patients holding the brain for about 5.5 is difficult. Now we are working on a way to reduce by half by using deep learning technique. Well, imaging slab is oriented perpendicular to the fourth ventricle floor shown here, so that we can have the homogeneous locus coeruleus as shown on the image. And these are 2 results of the 2 different resolutions. The one on the left is using low resolution images. On the other end, the one on the right is having the high in-plane resolution, so that you can have better delineation of these locus coeruleus structures. And if you compare this technique to other, conventional neuromelanin imaging techniques, we can see that the result of our sandwich neuromelanin is higher in terms of its CN contrast ratio, and it gives reasonably high SNR, so that you can use it for the detection of the volume or contrast. Well, by simply looking at these comparison images, you may say that, okay, you have seen a better images, and I have those better images on the right, and they are from the literatures. And yes, I agree that some of them has better contrast or better, SNR, but they are usually using a longer scan time, and also they sometimes have this customized empty pulses that they are using, which takes a longer, which is not easy to have, and it's a pretty cumbersome thing. Every upgrade of the software, you need to have another sequence implanted for your scanner. So that's the thing that we want to avoid for this application. And this is a result of multi-vendor study, where we had 3 vendors showing a very consistent contrast by using this sandwich neuromelanin. On the other hand, the MT pulse provided by the products provided by the vendors, and using the GRE acquisition, the same as the sandwich neuromelanin, has a large variation of the contrast. And they are also confounded by this standard deviation. So this is subject 1, 2, 3, 4. And if you look at their standard deviation, the value is much smaller in sandwich neuromelanin as compared to conventional method. And another thing that we performed was this test-retest scan of the technique on 5 subjects, reporting higher intra-class coefficient and lower coefficient of variance. So that tells us the reliability of the technique, that you can use it for the reproducibility study. Well, as the preliminary result of the Parkinson's patient versus healthy control, we scanned about 35 to 38 IPD patients and also healthy controls with age matching. And this IPD patient had the slightly early stage, Parkinson's with mean disease duration of less than 3 years. And we used this deep learning-based automatic segmentation so that we can measure volume without much pain to measure them. And you can definitely see the volume changes, volume decrease, or volume difference between the control and Parkinson's disease. And the p-value is pretty high. Having said that, measuring this volume and getting the individual, identification of the disease may not be simple by using this volume. I believe Dr. Hake's presentation on how you combine this one with SMWI will be a good candidate to go for better diagnosis of the patient. So if I summarize the tool number 2, it is about sandwich neuromelanin imaging for the Parkinson's disease. We have this product sequence with regional saturation pulses. It's very simple, and you can program it in your scanner without any need from the engineers. It's just very simple approach to set up the protocol and run it and get high quality images. And we have these 2 protocols that runs at 5 minutes and a half. And the protocols are available under the name of the first author, Suyeon Ji. So that's one good thing to have. Well, I have a lot of questions how we do the quantifications and whether this neuromelanin contrast is really specific to the neuromelanin as we have seen that in histology, you will see a sporadic distribution of the neuromelanin clusters, whereas all of these neuromelanin MRI doesn't show that type of signatures in our images. So the specificity to the neuromelanin MRI may not be well studied or well understood. So that can be one of the topics that we may explore with this conference or symposium. Okay, having said that, let me move on to my last topic, which is Chi separation. Again, this is susceptibility source separation technique toward iron and myelin mapping. This is a little bit busy slide, but let me walk you through one by one. So let's consider a voxel, voxel at the center of the imaging volume. And we can assume that this voxel contains not just a few of them, but a bunch of these susceptibility source. And let's consider that these susceptibility sources are positive in value, and they have this homogeneous and isotropic susceptibility, meaning that characteristic frequency is the same in all of them, and they have the same, like cylindrical or spherical structure of the same radius. And also, we need to assume the static dephasing regime to have this equation on the right. And once you have those sources, and if you put it into the B0 field, then you will have this field perturbation, which if you walk out from that voxel and see globally, then that's the pattern that you get as the sum of all this small field perturbation. And what is good about this field perturbation, in microscopically, it induces additional signal decay, so-called R2 prime decay, and together with R2, we get R2 star contrast. And here are the two equations that we can find from the literature, where your R2 prime is directly proportional to the absolute value of the susceptibility concentration. And also the QSM literature shows that, frequency shift here shown as the, as the dipole pattern convolved with the susceptibility source of the voxel. Susceptibility concentration of the voxel is the field pattern that you get from phase of your MRI data. Let's consider another case where you have exactly the same voxel, but now we negate the sign of this, susceptibility sources. Again, the same size, same characteristic frequency, but we have the sign negated. Then everything is the same in terms of the magnitude decay or R2 prime value, but the sign of the field pattern that you get from this source is now the opposite. So that's the reason why we have this absolute value in our R2 prime. On the other hand, here we don't have any absolute value so that we can accommodate this sign change in the equation. Well, for us, the real question is what will happen if you have the two of them summed together? And then the result is from the outside, these field susceptibility patterns will have the cancellation effects. So now you have slightly new equation, but this is not really the new equations. They are just straightforward extension of the previous equations. And then when it comes to the signal decay, the effect of R2 prime is added as expected from the equation. And then once you have these two equations, now you can solve for this positive and negative susceptibility sources separately and generate the map based on our reconstruction techniques for the QSM. There are multiple options of it. I'll talk about these options soon. If I can show you the overall pipeline of this chi separation, we need to acquire two different data sets. The first one is multi-echo, gradient echo, so that you can have this R2 star map as well as frequency shift map. And the other one we need to have is this multi-echo spin echo data for the R2, so that you can generate this R2 prime. And together with frequency shift, we can put them as the input of the chi separation algorithm, generating these positive and negative susceptibility maps. Again, you have multiple reconstruction options. Just like the QSM reconstruction, you can have this MEDI regularization so that you can use this single orientation R2 prime and field map so that you can generate this positive and chi negative. this technique still suffers from streaking artifact from the same reason as the conventional QSM suffering from the streaking artifact. You can acquire multiple head orientation data for the R2 star so that you can have this cosmos reconstruction for the chi separation. Now you get a pretty good reconstructed images. The challenge here is, again, a long scan time, also the need for the R2. Once you have neural net, you can resolve a lot of things under, as long as you are happy to tolerate some of the errors from the neural net. And then you can get rid of these R2 data sets and simply supply this R2 star data as the input of the neural net. And then train the neural net such that your neural net generates the chi separation result of the quality of the cosmos chi separation. And then neural net with a tolerable range of errors that whether it really depends on whether you accept the errors or not. But anyway, to a certain extent of errors, you can generate the high quality chi separation result that looks really nice at least by eyes. Anyway, before we go to the in vivo applications, we were very much willing to explore how it really behaves in for the validation. So the first one that we did was Monte Carlo simulation. Here we had 9 cylinders. The first rows has 3 different concentration of the positive susceptibility source. Second one, negative susceptibility sources. Third rows having both positive and negative sources. We mixed them together and generate the frequency shift and R2 prime maps, and from which we apply these chi separation tools to generate the 2 separated images. The result are perfect agreement with our assignment of the susceptibility sources, demonstrating that it works in the computer simulation. The same story goes for this phantom experiment using 3 different concentration of iron and 3 different concentration of calcium and the combined cylinders, resulting in exactly the same scenario and the result as shown on this right plot, confirming that the algorithm works for the phantom as well. The question is whether this technique really works for the brain or not. As we know, the good thing is in the brain, except a few exceptional cases of increased calcium or zinc or copper, we can safely say that myelin is negative susceptibility source and iron is the positive susceptibility source that dominates the susceptibility sources in the brain. And also, what we know is most of the brain area contains both sources. So we really need to separate the 2 so that we can tell about the sources. Another thing that we have to assume is we have to assume that susceptibility is the primary source for the R2 prime and frequency shift, which may be valid in most of the cases, as we know the exchange only explains about 1/10 of the contrast for the frequency shift. The last one that we want to make sure is this static dephasing regime assumption. It may be okay for the area where we don't have high concentrations of susceptibility or large diffusivity. And if you assume, the challenge is, despite the fact that we assume all of them is okay, we still cannot, escape from the fact that susceptibility is not really homogeneous or isotropic, as we have this myelin and it has elongated structures that induces a lot of different things in our frequency shifts. So there are limitations of it. So our question is, what will happen if we just ignore the last factors and apply the technique and see whether we can get reasonable outcomes from our chi separation result? And this is the first result by using the technique for the brain specimen, where you can see this positive susceptibility map and negative susceptibility map, and you can compare them with the myelin stain and also ion quantification result on the left. And you can see a pretty good correlation between the 2, especially in the cortical layers. You can clearly see delineation of this line of generic locations, not only the iron maps, but also in the myelin maps. And also white matter bundles seems to show a similarity in terms of their contrast between myelin stain and iron, the chi negative map shown on these 2 images. Well, we also went for the in vivo data set, where when we look at this big gray matter and compare the result to the literature result, which seems to be okay in terms of their correspondence between chi separation and histology result. And this is one of the results that I really like about, and this is the myelin histology result, and this is ex vivo on negative chi susceptibility map, the resolution of 350 micrometer. And this is the in vivo result of 0.7 millimeter isotropic voxels. What we can identify from these images is the fact that this pallidum and globulus pallidus has laminar structures, as has been demonstrated in the histology. We can have multiple layers well identified in the not only the ex vivo map, but also in the in vivo map as well. So that was very exciting result that I was very happy about having the tool. And the last one that we had was not the last one, but another, first, the clinical study that we did was this MS patient study, where you can identify this iron rim lesion with demyelinated MS core. That was another very easy target to see the result. And we went on for further application of the technique, and this particular study was, excited by the result of Dr. Kirillina recently published in Science Advance, showing this profile of myelin as well as iron. And we choose some of the fundus of the cortex so that we can find the averaged profile of the laminar structures, not only in the cortex, but also all the way to the white matter, so that you can see this superior white matter region, where we can see that chi positive peaks around the superficial white matter region, whereas the myelin really peaks at the deep white matter that are consistent to this histology result. On the other hand, if you look at the profiles of QSM or R2 star, they don't really match to the chi positive profiles. So I believe there are variations that are influenced by the myelin contribution on those data sets. And finally, this is the one that we acquired the data in 20 minutes on a subject at 3 Tesla. And this is the isotropic 0.7 millimeter resolution with deep learning reconstruction as well as deep learning processing that really gives you the high quality chi separation results, both negative and positive maps. And I believe this map has a lot of potentials of analyzing different parts of the brain at the same time as the substantia nigra and nigrosome areas. For the Ph.D., we still doing the research on the clinical evaluation of this chi separation. So it is on the way. So stay tuned about the result. We are not the only group doing this chi separation or susceptibility source separation. There are more papers coming up from different groups, and we are very excited to see our result and as well as their results. So if I go to the almost my last slide of the tool summary for the tool number 3. This chi separation is a new tool for advanced QSM. It has a lot of assumptions, and we don't say that positive susceptibility map is the same as iron map, nor negative susceptibility map is the same as myelin map. Still, we believe they do carry some of the important information that can be interpretable and usable for the clinical diagnosis. And deep learning seems to do a lot of good jobs in reconstructing and processing the result. And we have this alpha version toolbox that we begin to share with other people. So if I do the grand summary of my presentation, we have these 3 tools that may or may not work for the Parkinson's, but some of them are very definitely helpful in diagnosing Parkinson's disease. And the first tool was the SMWI for the nigral hyperintensity. The second one was this sandwich neuromelanin for the neuromelanin imaging. The last one is chi separation, that I believe it has a lot of potential for the Parkinson's disease. With that, I want to thank you for your attention, and this is my lab at Seoul National. Thank you.